next going to the liver tumors. Okay, liver tumors. We are going to discuss. We are going to discuss on the three headings: benign tumors of liver, HCC, and metastasis. These are the three topics we are going to discuss in this liver tumors. Now let me discuss the benign tumors of liver. Though it's a very small topic, just have an idea of the benign tumors of liver. So benign tumors of liver are the following three. They are hemangioma, FNH, and adenoma. Hemangioma, FNH, and adenoma. So please remember, FNH and adenoma are common in females. Adenoma is common in young females. FNH is common in middle-aged females. And hemangioma is equal in male and female. Okay, it is equal in male and female. So which is most common tumor of these three? The most common of these three is hemangioma. So the most common incidentaloma, we usually call it as most common incidentaloma, is hemangioma. The most common incidentaloma is hemangioma. So please don't forget, hemangioma is the most common incidentaloma. FNH and adenoma. So in this, you must remember, OCP is a strong predisposing factor for adenoma. OCP is a strong predisposing factor for adenoma. OCP is associated with FNH also. It is associated with FNH also. Okay, and when there is no such cause for hemangioma, there is no etiology seen for hemangioma, but OCP is associated with adenoma and FNH. And I want you to know the important points regarding FNH and adenoma, all these things, is about the complications. So usually hemangioma is whatever the size it may become. Very rarely it goes for rupture. Very rarely it goes for rupture. And it can become very big when it is more than 5 centimeter size. It is known as giant hemangioma, and such giant hemangioma can cause one complication known as Kasabach-Merritt syndrome. What is Kasabach-Merritt syndrome? Kasabach-Merritt syndrome is a condition in which huge hemangioma consumes the platelet and cause consumptive coagulopathy. Will consume the platelets and cause consumptive coagulopathy. They will consume the platelets, cause consumptive coagulopathy and congestive cardiac failure. Huge giant hemangiomas can consume the platelets and cause consumptive coagulopathy, congestive cardiac failure, and thrombocytopenia. That is known as Kasabach-Merritt syndrome. Please don't forget, national board question. So Kasabach-Merritt syndrome is a complication of hemangioma. It can rupture, but there is no chance of malignancy. FNH can also go for rupture, but no chance of malignancy. But adenoma can rupture, and there is chances of malignancy present. Malignancy chances is present. Rupture is also present in adenoma. So adenoma is more dangerous because there is high chances of rupture seen. There is high chances of rupture seen. So CT scan is the investigation of choice for all these lesions. How to differentiate all these lesions is by CT scan. So CT scan will show you the classical findings in all the three. I will show you what are the findings. In hemangioma, if there is a lesion in the liver like this, it will show slow enhancement from periphery to center. Slow contrast enhancement will be seen. On a contrast CT, there is slow enhancement from periphery to center. So please remember, CT scan will show slow enhancement from periphery to center. I will show you the image. So all CT scan I will show you. You have to know those images. From slow enhancement from periphery to center. FNH will show you classical finding on CT scan. What is it? What is this finding in an FNH? In FNH, there is a central stellate scar. Please don't forget. In FNH, there is a central stellate scar seen on CT scan. In adenoma, what is the CT scan finding? There is early enhancement of the lesion. The moment you give contrast, immediately the lesion gets enhanced. Early enhancement is a feature of adenoma. So please don't forget. FNH will have central stellate scar. Hemangioma will show slow enhancement from periphery to center. Early enhancement is seen in adenoma. And if you have a doubt, you can do sulfur colloid scan. In sulfur colloid scan, it is a scan which picks up what? Which picks up Kupffer cells, functioning Kupffer cells, and therefore it is hotspot only in FNH. So which tumor appears as hotspot in sulfur colloid scan is FNH is the only tumor which contains functioning Kupffer cells, therefore it appears as hotspot. Okay, so in coming to the treatment, hemangioma needs no treatment. Adenoma also needs no treatment unless they both produce any symptom. Unless they produce any symptom or complication, no treatment needed for adenoma and no treatment needed for hemangioma and for FNH. But adenoma always needs resection because of malignant potential. Because of malignant potential, it needs resection. Okay, it needs resection. Some extra edge from adenoma. I want to tell some extra edge points from adenoma. So there is most commonly adenomas are single, and such single adenomas are more common in females. In fact, it is exclusively seen in females than males. But it can be multiple in 20% cases. In 20% cases, it is multiple. When it is multiple, it is not associated with OCP. Please remember, it is not associated with OCP if it is multiple. If it is multiple, it is not associated with OCP, and there is no female preponderance. So please remember, 20% cases may have multiple adenomas, multiple adenoma all over the liver, and such cases not associated with OCP and no female preponderance is seen, and those cases will need liver transplantation. Multiple adenomatosis will need liver transplantation. And there is one mutation known as beta-catenin mutation. If the adenoma has beta-catenin mutation, what is the problem? If the adenoma has beta-catenin mutation, please remember, they have high risk of malignancy. High risk of malignancy is seen if there is beta-catenin mutation seen. So beta-catenin mutation patients will have high risk of malignancy. So this point is an MCQ for exams. So has high risk of malignancy and they need yearly surgery. For these patients. So please don't forget these three benign tumors, and the benign tumor which can go for malignancy and rupture in 50% of the patients. Rupture is seen in adenoma. So the adenoma, the moment you diagnose, should be resected. If it is multiple adenomatosis, we have to do liver transplantation. So multiple adenomatosis is associated with no OCP predisposing, no female preponderance. So it can be more problematic than a single adenoma lesions. Okay, please don't forget this point. And now we are coming to the most common malignant tumor of liver. What is the most common malignant tumor of liver? Can you tell me? So most common malignant tumor of liver, everyone knows METs. So we will discuss about METs later. Most common primary malignant tumor of liver is hepatocellular cancer. So let us discuss about now hepatocellular cancer. Most common primary is hepatocellular cancer. It is predisposed by infections. So mainly by what infection we get HCC? It is by hepatitis B virus infection and hepatitis C virus infection. And other predisposing factors are cirrhosis. Cirrhosis of the liver due to alcohol induced, or autoimmune cause of cirrhosis, or biliary cirrhosis, any cirrhosis, or the other etiological factors is environmental. Environmental risk factors for HCC are aflatoxin, thorotrast, pyrazolidone alkaloids, and there are so many other environmental risk factors. And please don't forget the congenital metabolic disorders as the last. Metabolic disorders like alpha-1 antitrypsin deficiency, Wilson's disease, hemochromatosis, and anything you want. You can just think of glycogen storage disease, anything like any metabolic disorder can cause HCC. One interesting point I want to tell you here is whatever may be the predisposing cause, the liver will first of all go to cirrhosis. From cirrhosis only the cancer arises. Please remember, from the cirrhosis only the cancer arises. It will not arise from a normal liver. Okay, so always from a normal liver it goes for cirrhosis, then only HCC arises. Can you tell me the only one reason where the normal liver develop HCC? Normal liver can develop HCC without going for cirrhosis. The only etiology is hepatitis B virus. So this is the Ames question. So the one etiology which can cause HCC without going for cirrhosis is hepatitis B virus infection. Please don't forget this. So what are the clinical features of this condition? The common clinical features are, the most common clinical feature of HCC is a known case of cirrhosis. Please remember, is a known case of cirrhosis. He comes to you now with a pain, weight loss, mass, are the various features in a known case of cirrhosis. The most common presentation is pain, weight loss, mass. And a known case of cirrhosis patient suddenly becomes bad. I have myself seen around 3 to 4 patients, suddenly becomes bad. A known case of cirrhosis patient suddenly becomes sick and get admitted in hospital. Think of HCC. Think of hepatocellular cancer in these patients. Okay, so think of HCC. And these cases may have paraneoplastic syndrome. So HCC patients may have paraneoplastic syndrome. The most common paraneoplastic syndrome from Bloomgard, I'm telling you from Bloomgard, is not hypoglycemia. So not hypoglycemia, it is hypercholesterolemia. Is given in Bloomgard. Is more common than hypoglycemia. Why I am telling this? Because many books have given the most common paraneoplastic syndrome as hypoglycemia. It is wrong. The most common paraneoplastic syndrome is hypercholesterolemia followed by hypoglycemia, and others are hypercalcemia and polycythemia. So please don't forget, this is from Bloomgard liver book. Okay, so the most common paraneoplastic syndrome in HCC is hypercholesterolemia followed by hypoglycemia. Others are hypercalcemia and polycythemia, also known as erythrocytosis. Can somebody tell me what is the most common paraneoplastic syndrome in RCC? In RCC, it is increased ESR. Please don't forget, increased ESR is the most common paraneoplastic syndrome in renal cell cancer. In HCC, it is hypercholesterolemia. And if you see the types of HCC, presentation can be like this. The HCC can be a hanging HCC. I'm going to show you one patient we operated a hanging type like this. So there is no infiltration to any important structure. So this is hanging type. And then comes pushing type. This is a pushing type. This will push the vessels and bile duct, but there is no infiltration. This is pushing type. It will just push the bile duct. That's all. It will push the bile duct and vessels, but there is no infiltration. And the third type is infiltrating type. That bile duct, hepatic vein, artery, anything can be infiltrated by the tumor. That is known as infiltrative pattern. So which is having the bad prognosis is infiltrative have bad prognosis, hanging type has good prognosis. So the patterns of HCC are hanging type of HCC, pushing type of HCC, and infiltrative type of HCC. And this is the best prognosis, which is hanging type. So now your patient comes to you with a suspected HCC is coming to you. What are all the investigations we are going to do now for him? So investigations done for HCC in the background of cirrhosis is tumor markers. We will do tumor markers. So Sabiston says if AFP values, alpha fetoprotein is more than 20 nanograms per ml, it is 70% suggests 70% positive for HCC. This is a line from Sabiston. Sabiston says if AFP, alpha fetoprotein, is more than 20 nanograms per ml, it is positive in 70% of the HCCs. If it is more than 400 nanograms per ml, it is conclusive of HCC. If it is more than 20, it is suggestive of HCC. If it is more than 400, no doubt it is conclusive of HCC. So alpha fetoprotein is a tumor marker commonly used for HCC, but we have now new tumor markers like glypicon 3, PUCA. What is PUCA? This is an expected, already asked MCQ. Protein induced vitamin K absence. So the name is known as protein induced vitamin K absence. So PUCA is one tumor marker, new marker, glypicon. I have done spelling, glypicon 3. Okay, AFP leptin 3 fraction, AFP leptin 3 fraction, which is leptin 3. So these are all new tumor markers. In this, the question asked in exam is on PUCA. Protein induced vitamin K is asked in the exam. So please don't forget, it is also known as descarboxyprothrombin. Other name is descarboxyprothrombin for this. So protein induced vitamin K absence is also known as descarboxyprothrombin. Other tumor markers are glypicon 3, AFP leptin 3 fraction, and PUCA are the tumor markers. But we don't depend on tumor markers alone solely. The investigation of choice for HCC is triple phase CECT abdomen. CECT abdomen with the triple phase we do. Triple phase is done. So we have triple phase CT scan. In this triple phase CT scan, we will see the tumor is supplied by hepatic artery. Therefore, there will be rapid contrast flow into the tumor, followed by rapid washout. This is a classical finding of HCC. Early enhancement of the tumor with a rapid washout is seen in triple phase. I will show you that. So in a plain CT, the tumor will not be seen. But once you give the contrast, in hepatic arterial phase, the tumor will be very brightly seen and will be rapidly washed out. And in portal venous phase, the tumor will not be seen. So to know about phases, you have to know in detail about those phases. There are many phases like early arterial phase, late arterial phase, portal venous phase are the various phases. Early arterial, late arterial, and portal venous phase are the various phases. The HCC will get enhanced rapidly in the arterial phase, and by the late arterial phase itself will be washed out, and it will be looking not seen in portal venous phase. So this is a classical finding of CT scan in case of HCC. So HCC we used to tell We used to diagnose if the size of the lesion is more than 2 centimeter. The size of the lesion is more than 2 centimeter with typical findings as I told you. No further investigation needed. So typical findings as I showed you, this is enough. So more than 2 centimeter with a yearly enhancement and rapid washout, the diagnosis is confirmed. Diagnosis is confirmed with this itself. Okay, we can confirm this with this itself. If the lesion is 1 to 2 centimeter only, we have to need two imaging techniques like CT and MRI. Like the two imaging techniques are needed for 1 to 2 centimeter. More than 2 centimeter, one imaging technique is enough. This is from NCCN guidelines. One imaging technique is enough if it is more than 2 centimeter. If it is 1 to 2 centimeter, two imaging techniques are needed. Two imaging techniques are needed. Will you do a biopsy in HCC? Already I told you, in pancreatic cancer we don't do biopsy. Similarly, for any liver lesion, biopsy is contraindicated. We should not do biopsy. When you do biopsy, you will disseminate the tumor. Biopsy is advised only for inoperable cases for tissue biopsy. For tissue diagnosis, inoperable cases only we can take biopsy. Otherwise, biopsy is not at all needed for HCC. Not needed for HCC. So when you discuss about HCC, you must know about some staging systems. You must know about some staging systems, which is not so important. Just for completion, I'm telling you the stagings. They are known as Okuda staging. Cancer of liver Italian program staging. Cancer of liver Italian program staging. Cancer of liver Italian program staging and Chinese University Prognostic Index. Chinese University Prognostic Index. Just I'm telling the names because national board exam can ask one-liners. Chinese University Prognostic Index. So Okuda staging, CLIP staging, cancer of liver Italian program, Chinese University Prognostic Index are the old staging systems. If at all, they will ask you Okuda staging, which is carrying tumor, albumin, ascites, and bilirubin. So that is remembered by the mnemonic tab. Tumor size, albumin, ascites, and bilirubin are taken into account. So Okuda staging contains what are the factors means remember as tab. Tumor size, albumin, ascites, and bilirubin will be included in these stagings. So but these are not important for PG level. Just know the name Okuda, CLIP, CUPI. What is very essential? What is the latest staging system for HCC? Latest staging system. Can you tell me? So that staging system helps in diagnosing as well as treating as well as for multi-purpose. It is also tells about the prognosis of the patient. There is a huge table column given in your substance. So what is that staging system? That is known as Barcelona Clinic. That is known as Barcelona Clinic liver staging system, BCLC. Okay, Barcelona Clinic liver staging. So very simple staging system which helps you to diagnose as well as to treat under various headings. The headings are, so number one is very early stage. The tumor is very early stage, and then early stage. So the tumor is early stage, and then comes intermediate stage. Then comes locally advanced stage. Locally advanced stage, and then comes terminal stage. Like that we have stage. In this I would like to tell you only a few points. Very early stage is a tumor single less than 2 centimeter. That's all. So early stage, very early stage is less than 2 centimeter single tumor. Early stage is a tumor less than 3 lesions. All less than 3 centimeter size is known as early stage. All less than 3 centimeter, less than 3 lesions are known as early stage. Don't worry about the advanced stage and terminal stage, but this is the staging. Based on this they manage. Less than 2 centimeter single stage, best treatment is what? Resection of the tumor. Resection of the tumor. And that is for early stage we can also advise liver transplantation. Can also be advised for early stage cases. So now let me tell you the treatment modalities based on these points. Treatment modalities. Treatment modalities. If you diagnose a HCC, the best treatment modality is what? The best treatment modality is resection. If you are possible to resect the tumor, resection is the best treatment modality. If it is possible to resect, please resect it. That is the best treatment modality. And if you can do transplant, because HCC arises in the background of cirrhosis liver. You all know it arises from the background of cirrhosis liver. So if you can do transplant, liver transplant, is it indicated or not for HCC? You can wonder how can you do liver transplant for a cancer patient? Can you do? Yes or no? Yes, we can do. Liver transplant can be done for HCC patient by a criteria known as high yield MCQ for you, Milan criteria. So Milan criteria. I'm going to discuss about Milan criteria. So the best method of treatment is resection of the tumor. For example, if there is a tumor here like this, we have to resect the tumor. In a cirrhotic liver, after resection, how much percentage of liver should remain? Future liver remnant, how much percentage of liver should remain in a cirrhotic liver like this? So FLR should be at least 40%. In a cirrhotic liver, FLR should be 40%. So please remember, in a cirrhotic liver, FLR should be 40%. In a normal liver, how much should be the FLR? In a normal liver, FLR should be at least 25%. Otherwise, the tumors are said to be inoperable. So please understand the concept. If this is a tumor, if there is a liver, it is a liver, and if this is a tumor here, after removing the tumor by giving clearance, there should be at least 40% of the liver remaining in a cirrhotic liver. At least 25% should remain in a normal liver. If it is not remaining, we cannot do resection. So we cannot do resection. Okay, the contraindication of resection is when there is no adequate FLR. When there is no adequate FLR, we cannot do resection. And when you go for liver transplantation, the criteria to do liver transplantation is Milan criteria. The tumor should be single, less than 5 centimeter size, or it should be less than or equal to 3 lesions, each less than or equal to 3 centimeter size. That is another point. 3, no extra hepatic spread. So according to Milan criteria, when can you do liver transplantation means when the lesion is less than 5 centimeter single, when there are less than or equal to 3 lesions, less than or equal to 3 centimeter size, and when there is no extra hepatic spread, you can do liver transplantation according to Milan criteria. So for the other cases, what are the treatment done? The other cases for whom we cannot resect, So for whom we cannot resect and who are inoperable and who are poor performance patients, those cases we do ablative therapy. What are the ablative therapies we know are percutaneous ethanol injection. Number 1, percutaneous ethanol injection. If it is a tumor, percutaneously we can put ethanol into the tumor. So percutaneous ethanol injection. Percutaneously we can put ethanol, we can put acetic acid, or percutaneously we can do thermal ablations. What are the methods of ablations? Percutaneous thermal ablation techniques. or like RFA, radio frequency ablation, cryoablation. So the ablative therapies we have are percutaneous ethanol injection, percutaneous acetic acid injection, or percutaneous thermal ablation like radio frequency ablation and cryoablation. At this point, I would like to tell you one important thing that is known as heat sink effect. What is this heat sink effect? Heat sink effect is seen in patients who have tumors very close to the blood vessel. For example, this is a tumor, this is a blood vessel. When I pass radio frequency into this tumor, the heat energy will be carried out by the blood vessel and the heat will sink. So heat sink effect is seen near blood vessels. Remember this one-liner. So heat sink effect is seen near blood vessels. When I'm using percutaneous thermal ablations like radio frequency ablation or cryoablation, there will be heat sink effect seen. Heat sink effect will be seen. So these are all ablative therapies by percutaneous method. Percutaneous ethanol, acetic acid, radio frequency, cryotherapy. Or else we can use the concept of the tumor gets 100% of its blood supply from where? If there is a tumor in the liver, 100% of the blood supply comes from hepatic artery. So therefore, into the hepatic artery, we can inject chemotherapy agents through the hepatic, we can cannulate the hepatic artery and we directly infuse chemotherapy agents into the hepatic artery known as transarterial chemoembolization. TACE. So the chemotherapy particles are carried on by lipoidal medium. The medium used to carry the chemotherapy particles are lipoidal medium. We can use 5-fluorouracil, cisplatin or various chemotherapies are carried onto the artery directly to the tumor. So when you use a lipoidal oil, that will directly carry the chemotherapy to the tumor. So lipoidal medium is used in carrying the chemotherapy. So these type of artery approach procedures are known as transarterial chemoembolization, transarterial radioembolization. Please don't forget these two names, TACE and TAR. Transarterial, we can also put radiotherapy particles. We can also put radiotherapy particles. Transarterial chemoembolization, transarterial radioembolization are the various other procedures used. Okay, are the various other procedures used. So now coming to the property of this tumor, property of HCC, please don't forget, this is a tumor which can grow into hepatic vein, which can grow into portal vein. Please remember, this is a tumor which can grow into hepatic vein and it can grow into portal vein. Growing into portal vein carries worst outcome. By these ways, if you see how many percentage of HCC are operable means 10 to 15% only will come as operable HCC. So therefore, if you see around 90% of them are inoperable cases, around 90% of them are inoperable patients. So for inoperable patients, we can give them one palliative chemotherapy. What is the latest approved palliative chemotherapy for HCC patients? That is what? It is a multi-kinase inhibitor. It is a multi-kinase inhibitor known as sorafenib. Sorafenib is a drug used for inoperable HCC. It is, what is this? So multi-kinase means it is serine 309. It is serine 309. It is serine 309 kinase inhibitor. It is VEGF inhibitor. It is tyrosine kinase inhibitor. It is platelet-derived growth factor inhibitor. So it is a multi-kinase inhibitor. Serine 309 kinase inhibitor, VEGF inhibitor, tyrosine kinase inhibitor, and platelet-derived growth factor inhibitor. So by giving sorafenib, the survival is increased for about 6 to 9 months. By giving sorafenib, the survival can be increased for about 6 to 9 months. The survival can be increased. So please don't forget sorafenib. It is a serine 309 kinase inhibitor, VEGF inhibitor, tyrosine kinase, and PDGF inhibitor. So this is what we use in inoperable cases. Inoperable cases. In case of inoperable patients, we use this sorafenib. Now coming to the rare type of tumor known as fibrolamellar HCC. So fibrolamellar HCC, how does it differ from normal HCC? How does it differ from normal HCC means fibrolamellar HCC is equal in male and female. It is equal in male and female, or it is little more in females. It is mostly equal in male and female. If at all, it is little higher in female. It is common in young age. An interesting point here is the liver is normal. I told you in HCC liver will be cirrhotic. Here the liver is normal, and here hepatitis B virus, hepatitis C virus are all negative. They are all not positive. They are all not involved. They are negative. So liver is normal, no hepatitis B virus, no hepatitis C virus, and there is no cirrhosis. And please don't forget, they don't have no AFP elevation. So AFP is not elevated in fibrolamellar cancer. Instead of AFP, they have a new tumor marker known as high yield MCQ neurotensin B. Already asked in national board exams, neurotensin B is a tumor marker for fibrolamellar cancer. So they are common in young, equal in both sex, and liver is normal. Viral markers are negative, no AFP elevation, and they have neurotensin B increased. An important point is on CT scan of fibrolamellar cancer, what is the important differential diagnosis? Differential diagnosis FNH, because both have central scar. In fibrolamellar cancer also, you get a central scar. So fibrolamellar cancer as well as focal nodular hyperplasia both have central scar. So the important differential diagnosis of fibrolamellar cancer is FNH. So please remember, you have to differentiate it from FNH cases. FNH cases, you should differentiate this. Now coming to the last topic, it is metastatic tumors. Metastatic liver. So to the liver, now the metastasis comes. To the liver, there are now metastases. What is the most common primary for liver mets? What is the most common primary for liver mets? Can you tell me? Very well known answer, no confusion in this. It is colorectal cancers. Okay, colorectal cancer is the most common primary. Okay, and which primary has best prognosis? So colorectal can produce, gastric cancer can produce, breast can produce, anything can produce liver mets. Which will have best prognosis? Among the various metastases, best prognosis is seen with neuroendocrine mets. Have the best prognosis followed by colorectal cancer mets. So please remember, the most common primary is from colorectal cancers, and the best prognosis is from neuroendocrine, followed by colorectal cancer. Therefore, resection is possible for these two tumors only. Resection is advised for these two mets, for colorectal cancer mets and neuroendocrine tumor mets. These two tumors we can advise resection. We can advise resection. Okay, and the liver mets can be two types. The liver mets can be of two types. They are hypodense mets. Hypodense, the liver looks bright, and the mets are hypodense. Hypodense mets. Another mets is hyperdense mets. So the liver is looking black, or liver is in a portal venous phase. In a portal venous phase, you see this. This is done in portal venous phase. Okay, it is done in portal venous phase. In portal venous phase, the liver is bright and the mets are black. In arterial phase, the liver is black like this. So remember, the liver is black like this, and the mets are bright like this. The mets are bright like this. So what are the mets which are hypodense? Can you tell me? So in portal venous phase, the liver looks bright and we can catch the mets. And portal venous phase, the hypodense mets or colorectal cancer mets. GIT mets, GIT mets, lung mets. From lung cancer, the mets, head and neck cancer mets, and sometimes even breast cancer mets will be hypodense. And never ever forget which are all mets which are hyperdense like this, neuroendocrine tumor and renal cell cancer. They have prominent mets. Neuroendocrine tumor includes insulinomas, malignant melanomas. So these are some of the places where you get hyperdense mets, So I told you we can operate colorectal cancer mets, you can operate neuroendocrine tumor mets, you can operate. So the 5 important prognostic factors, there are 5 factors which give the prognosis of colorectal cancer mets. They are: if the mets size is more than 5 centimeter, give 1 point. If size is more than 5 centimeter, give the patient 1 point. And if the patient had colorectal mets within 1 year, disease-free survival after right hemicolectomy or left hemicolectomy, disease-free survival is less than 1 year, you give 1 more point for that patient. So disease-free survival less than 1 year, size more than 5 centimeter or more than 1 tumor. If there are more than 1 tumor, give 1 point. If there is more than 1 tumor, give 1 point. Lymph node positive primary, previously the tumor operator had lymph node positive, give 1 point. And if the CEA is more than 200, give 1 point. So totally now you can see I have given 5 points. So colorectal cancer mets, bad points. What are all bad points means? If the tumor size is more than 5 centimeter, if the disease-free survival is less than 1 year, presence of more than 1 tumor, lymph node is positive primary, CA more than 200, and with all these things, we make a score known as Fong's score of prognosis. Fong's score of prognosis of the patient. I'll show you this score. This is from Sanderson. Fong's prognostic score. That score is known as Fong's prognostic score. So Fong's prognostic score, the question asked in any super specialty exams for the patient you are in Fong's score, what are the points included? The size of the tumor more than 5 centimeter, disease-free survival less than 1 year, more than 1 tumor, CEA more than 200, and lymph node positive primary is the one topic. So Fong's score is not essential for PG, it is essential for NEET super specialty. But for NEET PG, please remember the name Fong's score. Fong's score is for colorectal cancer mets prognosis. Okay, so please don't forget the table shown here. So what is the most common incidentoma and most common benign tumor is hemangioma, and which is the tumor which can go for rupture and malignant transformation is adenoma. Okay, and you can see this is hemangioma. From the image, you can see how it is slowly enhancing from periphery to center. Slow enhancement from periphery to center is hemangioma. And you can see a early enhancement in arterial phase. Early enhancement is adenoma. And never ever forget this image based question, high yield exam question. You can see there is a central stellate scar. It is FNH. FNH having central stellate scar. So this is a sulfur chloride scan showing you hot spot. Sulfur chloride scan showing you hot spot in FNH. So this point I forgot to tell you. The investigation of choice for SOL liver. Please remember this point. Investigation of choice for SOL liver. If the question comes like this, answer is CECT abdomen, triple phase. Please don't forget. You can see I am diagnosing all the lesions by triple phase CT only. So investigation of choice to diagnose SOL liver is CT abdomen, triple phase. If the question comes hemangioma, investigation of choice, answer is MRI. So MRI will show you this sign known as light bulb sign. MRI of hemangioma will show you a bright appearance known as light bulb sign. So for hemangioma alone, MRI. For all other SOL, if the question comes, it is CT scan, triple phase. So please don't forget hepatic adenoma, beta catenin type adenoma has highest risk of malignancy. Okay, so hemangiomas more than 5 centimeter are giant hemangiomas, and don't forget Kasabach-Weig syndrome. So we have discussed about this types of HCC, hanging type, pushing type, infiltrative type, and most common paraneoplastic syndrome is hypercholesterolemia followed by hypoglycemia from Bloomberg. So the latest tumor marker, Buca, don't forget protein induced, vitamin K absence, don't forget. And this is one of my patient. You can see in this patient there is a hanging tumor. I don't know how many of you can catch the tumor. There is a tumor hanging type of HCC. See, we are resecting the hanging type of tumor like this. The best method of treatment is resection, and you can see the tumor is resected. Recently done operation by us. The tumor is completely resected with a clear margin. This patient had AFP around 1000. And this is a picture showing you a typical HCC. So this is a classical arterial phase. Please remember, this is arterial phase. This is non-contrast. You can see non-contrast, no lesion is seen. But in arterial phase, there is a tumor seen, and in portal venous phase, tumor disappears. So yearly enhancement, rapid washout. Yearly enhancement, rapid washout. So the various staging, just remember the name alone: Okuda, Clip, Chinese, Barcelona. Barcelona is this big staging. Based on this, we will manage either by ablation, resection, transplant, taste, sorafenib. All these are various managements given by Barcelona staging. So Barcelona staging not only gives staging but also plans the management. Okay. So various ablative techniques. This is radio frequency ablation. Please don't forget heat sink effect. If this is kept near the blood vessel, that effect will be less because the blood vessel will carry the heat energy. That is known as heat sink effect. So sorafenib is a drug used for inoperable cancers, and don't forget melanotropia, size less than 5 centimeter or less than 3 centimeter, less than 3 lesions, no extra hepatic spread. We do liver transplant. So fibrolamellar cancer, what is the tumor marker? Neurotensin B. So please don't forget the points used for Fong's score. I told you the 5 points used for Fong's score. This is the Fong's score. Score number 1, the median survival is 51 months. Score total score is 5, the survival is only 22 months. So like that, with this we can make a prognostic score. Not important, just know the name. So this is a multiple mets. What is this mets known as? This is known as hypodense mets. And this phase is portal venous phase of liver. This is hyperdense mets. And this phase is arterial phase of liver. Arterial phase, you can see hyperdense mets. Hypodense mets are seen in portal venous phase. Please don't forget, GIT will have hypovascular mets. Renal cell and neuroendocrine will have hypervascular mets. So what is this picture showing you? So this is a liver cyst. This is a simple cyst of liver. So certain images I'm putting. Simple cyst of liver. The treatment is, if they are symptomatic, we do laparoscopic fenestration is done. Laparoscopically, we de-roof, open the cyst wall and we give it. So this is laparoscopic fenestration done for simple cyst. So this picture is showing you a cyst with a septal wall enhancement. That is a wall enhancement seen. What do you think this will be? Wall enhancement is seen. Therefore, it is a biliary cyst adenoma. Please remember this image is biliary cyst adenoma. Biliary cyst adenoma can go for malignancy. Therefore, we must resect the wall, complete wall. Resection advised for entire wall. We have to resect the wall. We should not leave back the wall because it will go for malignancy. So biliary cyst adenoma, resect the wall. And this is a classical picture seen in polycystic kidney disease patients known as polycystic liver disease. So polycystic liver disease. Whatever may be the number of cysts in the liver failure never happens. Interesting point, no? So liver failure never happens. Whatever may be the number of cysts in the liver failure never happens. But the major problem in these cases is they will develop polycystic kidney disease and renal failure. We treat these patients only for compressive symptoms. We do laparoscopically, we will remove the cyst for these patients. So PCLD patients will never develop liver failure, and the problem in these patients will be because of PCKD, they develop renal failure. So these are the points I want you to remember from tumor. So tumor is another small topic but full of high yield MCQs. So don't forget Kasabach-Merit syndrome. Don't forget Milan criteria used for liver transplantation. Don't forget FORM score. FORM score is for colorectal cancer meds. Thank you.